Hi everyone, and welcome to our weekly podcast brought to you by VJOncology. Today we'll be covering the latest updates and therapeutic innovations for genitourinary cancers. To begin, we're joined by Angela Jia from University Hospital's Seidman Cancer Center. We'll discuss findings from the Phase 3 STAMPEDE trial, investigating oncolytic viral therapy CAN-2409, and the development of an AI-driven biomarker detection model to guide more personalized therapy approaches in prostate cancer.
One of the abstracts was presented by Dr. Deweese. Very exciting. The first completed Phase 3 oncolytic viral therapy in localized prostate cancer, looking at predominantly in the intermediate and high-risk disease space, using this novel agent that's injected into the prostate over 3 injections. And they compared it against a placebo, so it was randomized and double-blind. And they showed there was a 30% relative reduction in disease-free survival. Interestingly, their disease-free survival is defined by absence of local, regional, distant failure or death. They also did a 2-year post-treatment prostate biopsy. And if the biopsy result was positive, that was counted as a local failure. This is not commonly done in Phase 3 trials, so huge credit to the investigators for performing this. But, while local failure is prognostic, certainly, and we want to avoid it because salvage treatment carries extra toxicity, local failure itself is not a surrogate for overall survival. So we're still waiting for long-term follow-up of this trial to see what the long-term benefits are. And for the STAMPEDE study, that was presented by Dr. James. Very exciting as it looks into whether a digital pathology-based biomarker can be used to select which patients would derive the greatest benefit from treatment intensification using abiraterone. And they showed that, when you have patients with a higher score that's called MMAI, multimodal artificial intelligence, that those are the patients that derived a bigger benefit. Of course, one thing that has remained to be seen is that STAMPEDE very high-risk patients are higher risk than today's very high-risk patients because now we use PSMA PET to stage. So it remains to be seen how this plays out in today's environment.
Thank you, Dr. Jia. Following on, Tian Zhang from Southwestern Medical Center discusses early findings from the Pedigree study, which studied tolerability of novel immunotherapy induction for renal cell carcinoma.
Pedigree is a trial we designed now over 10 years ago. It's an adaptive Phase 3 trial optimizing immunotherapy doublets for patients with metastatic kidney cancer. It is a trial that we've run in the cooperative groups, and we enrolled patients from May of 2019 to May of 2024, over 5 years. And over that time, we enrolled more than 1,100 patients. So this is a trial of all patients with metastatic kidney cancer with IMDC intermediate poor risk disease. And patients were first treated with step 1, which was ipilimumab, nivolumab doublet. And at the 3-month responses, treatments were adapted for their radiographic changes. So patients with complete responses received nivolumab, patients with progressive disease received cabozantinib, and patients with partial response or stable disease were randomized to either nivolumab or nivolumab with cabozantinib. Our primary endpoint was a 3-year overall survival. To improve that historical 60% to 70%, we needed about 553 randomized patients. This particular analysis that we're showing at ASCO 2025 is one of the step 1 demographics, step 2 assignments, and adverse events from step 1. And so this does not inform the primary outcome of overall survival. What we saw was that in this real-world population of over 1,100 patients, is a very diverse patient population representative of the U.S. population across the cooperative groups. Over 10% were Hispanic, Latinx, and also more than 8% were Black, Asian, or American Indian, Alaskan Natives. So that's a really impressive, I think, diverse patient population for the cooperative group setting. We also enrolled over 48% at community oncology centers across the U.S. And so really getting these immunotherapy doublets into the practices and hoping that improves our patient population outcomes. In addition, we also saw about 76% of patients with intermediate risk disease, 23% with poor risk disease enrolled to pedigree. There were a good number of bone metastases, about 27%, and also 54% of patients had de novo metastatic disease. When we looked at the step 2 enrollments versus step 1 discontinuation of these patients, we did see that fewer patients with poor risk disease as well as fewer patients with bone metastases were enrolled into step 2 than the population that discontinued during step 1. And of note, we saw the adverse events that we expect of immune therapies, so colitis, endocrinopathies, elevations in transaminases. Those were the main ones. We did see 15 patients who had grade 5 events from their adverse events, and that was a expected patient population from our more frail patient population, but it's certainly something that these early deaths on treatment are ones where we should take note of and try to improve upon. So we enrolled over the course of 5 years, and over these past decade, really, as Pedigree came into formation and the lifetime of the trial, we had over 7 industry phase 3 trials shape the landscape for metastatic kidney cancer. And I do think it is a testament to all the dedication from everybody. We had over 500 sites open Pedigree and over 450 investigators treated patients on Pedigree. And so it's really important to note that this is really a Herculean effort, big effort from a lot of our cooperative group settings.
Dr. Zhang also talks about pairing targeted treatments with radiotherapy for muscle-invasive bladder cancer, focusing on efficacy and emerging biomarkers.
So STAR-EB is an investigator-initiated trial that I designed with my colleagues Neil Desai and Saul Waldo at UT Southwestern. It is very much a multidisciplinary trial, phase 1/2, with a safety cohort of patients treated with enfortumab vedotin for 3 cycles and then escalating their time on radiation therapy. So the radiation therapy is first sequential after the 3 cycles, and then it gets moved up into the second and first cycles for that concurrent enfortumab vedotin with radiation. What we'd like to see is increased pathologic complete responses. All of these patients are receiving cystectomy after treatment, and we'd like to see patients have a pathologic complete response and therefore have good, data to support further development of maybe bladder preserving concepts with enfortumab vedotin and radiation. So we just launched, and we're about first cohorts all enrolled. And so we're following those patients carefully to see how they are doing on radiation and enfortumab and hopefully getting them to surgery soon. And we're open and enrolling for other patients with muscle-invasive cisplatin-ineligible bladder cancer.
Next up, we have Michael Harrison from Duke University School of Medicine, who evaluates quality of life in patients with renal cell carcinoma on active surveillance versus systemic therapy. What is the rationale for using active surveillance in the metastatic setting?
So the Odyssey study is a prospective observational study, so meaning that we accrue patients who are untreated with metastatic renal cell carcinoma, but we don't control in any way what they get as far as systemic therapy or no systemic therapy or what the specifics of those management strategies are. And so Odyssey really is 13 institutions across the U.S., across different networks within PCORNet. And PCORNet is an initiative of PCORI, the Patient-Centered Outcome Research Institute, that basically we're taking advantage of the fact that they have a common data model. So while the patients are accrued at sites and there's certain baseline data entered, their data is then followed longitudinally, centrally via PCORNet, and also through the Duke Clinical Research Institute, where they're administering patient-reported outcomes questionnaires by phone every 3 months at first for the first 2 years, and then every 6 months thereafter. So what we're trying to get at is the patient journey, and that's why it's called Odyssey. So the primary endpoint is actually around patient-reported outcomes, specifically using the instruments of the FIXI-19 and the FACT-G. And so we're looking, as opposed to clinical trials that look kind of, one therapy over one line, we're looking to follow the patient's journey potentially over multiple lines, but with the same instruments in the same timing. And so that's the idea behind it. And we're specifically interested in how real world patients, feel and function over time with these new regimens. We have 2 analyses. So one is on active surveillance, one is on systemic therapy. And so we're looking at the first 392 of 500 patients. And then so of those 392 patients, about 93 had no systemic therapy, at least initially on accrual, and the other 299 had systemic therapy. So the systemic therapy is a different abstract. So my abstract is on those 93 patients and really drilling down on the 53 patients who were classified as active surveillance. And how we determined that, again, we weren't controlling that in any way. We weren't randomizing. We simply asked the physician, did you select systemic therapy? Yes or no. If they did not select systemic therapy, we said, well, why are you doing what you're doing? And so these patients were the ones where the physician said they're either doing active surveillance with disease, present and stable, or no evidence of disease. And so we're focusing on those 53 patients. And so this analysis focuses on the median baseline quality of life findings, again, using FIXI-19 and FACT-G. And so we had a couple of interesting findings. So number one is that, as you might expect in Odyssey, the patients who underwent active surveillance had a better quality of life, whether you looked at FACT-G or FIXI-19 or the subscale of the FIXI disease-related symptoms. So that's not necessarily novel. That's what we expected to find. But I think the interesting finding is when we compared those same median baseline quality of life numbers to the patients who are in pivotal trials, our active surveillance population was actually very similar to those in the 4 pivotal clinical trials, whether you looked at Checkmate 214, Keynote, et cetera. And so what that suggests to us is that perhaps there were some patients that were enrolled on those clinical trials of systemic therapies that could have benefited from active surveillance. And that's what we're interested in learning more about.
Following on, we have Margaret Gatti-Mays from the Ohio State University who comments on SYNC-T therapy, a personalized cancer vaccine explored in patients with prostate cancer. How can you envision this changing the treatment landscape for prostate cancer?
So in the abstract by Dr. Tong and colleagues, SYNC-T therapy was administered to patients with metastatic prostate cancer that was resistant to endocrine therapy. This was an exciting abstract because in this SYNC-T therapy, which comprises cryolysis along with the administration of an adjuvant called SV102, was given to patients. And with the cryolysis, it is partial freezing of the tumor. So similar to cryoablation, but cryolysis is only freezing a partial of the tumor. The investigators were able to demonstrate by freezing or performing a cryolysis on soft tissue, either metastases or on the primary prostate cancer, that along with the administration of SV102, which was a mixed compound of low-dose immunotherapy agents, including an anti-CTLA-4, an anti-PD-L1, a CD40 agonist, and a TLR9 agonist, that with this combination of therapies, patients were able to have a very nice clinical response, including a disease control rate of approximately 100%. What was really exciting about this procedure or this therapy is essentially some of the patients responded very quickly with the median time to response at approximately 2.9 months. The other exciting part was that overall survival had not yet been obtained with 17 months of follow-up. And when the investigators looked at the exploratory outcomes, including the release of immunocytokines as well as the generation of polyclonal T cells, the investigators also found that the generation of an immune response correlated with better clinical responses. Again, I think this highlights the fact that these vaccines may perhaps be able to be used as a priming before other immunotherapy agents are used.
Thank you, Dr. Gatti-Mays. Finally, we have Stefanie Zschaebitz from Heidelberg University Hospital who talks on the value of combining targeted treatment with PARP inhibitors in prostate cancer, especially in subgroups with key HRRG mutations.
I presented some exploratory analysis of bi-gene subgroups and potential associations with efficacy. So we looked at different markers such as rPFS and OS and overall response rate, as well as PSA response and time to PSA progression. And just for a short memory, the Tadapruchi study is a phase 3 study that recruited patients that needed a treatment for first-line mCRPC. We started with recruiting patients that were an all-comer population, and those patients were prospectively tested for HR alterations as well. But once the cohort 1 was fully recruited, we started to recruit further patients with HR alterations. So cohort 2, that was the cohort that I presented, consists of patients that have HR alterations within their tumor. Patients received either talazoparib plus enzalutamide or placebo plus enzalutamide. And the primary endpoint of the study was rPFS and OS and turned out positive. So that was previously presented at ASCO GU. And we were looking into the sub-analysis or subgroup analysis of the by genes. And basically, HRR was defined as having one of 12 alterations within the tumor tissue or the ctDNA. And we used all data that we had from pre-screening and screening and decided to focus hence on 6 genes, as 92% of the population had one of these, or at least one of these 6 genes altered within their tumor or ctDNA. And we looked at rPFS and saw that for all 6 gene subgroups, which were ATM, CHEK2, BRCA1, BRCA2, PALB2, and CDK, patients had a benefit from the combination therapy. That was most pronounced for BRCA1, BRCA2 as expected, but also for CDK12 and PALB2, and not so much for CHEK2 and ATM, but still beneficial or more beneficial than the monotherapy. We then looked at overall survival, which again, not surprisingly, was better for patients with BRCA1 and BRCA2 alterations, but also for CDK12. And that was a little bit surprising because for monotherapy, we know that patients did not have so much benefit from the PARP inhibitor therapy. And we assume that might be possible or might be potentially because of the dual inhibition of the androgen receptor and PARP. And for the other endpoints, like overall response rate, 5 of 6 subgroups had a benefit from the combination therapy. And also for PSA progression and time to PSA progression and PSA response, all subgroups benefited from the combination. And that was something that probably not everybody had expected, because a lot of people thought that those effects might be driven by BRCA1, BRCA2 only, but the analysis showed that that was not the case.
Thank you to our speakers today, and thank you for tuning in. If you enjoyed today's episode, please leave a review and subscribe on your favorite podcast app, whether it's Apple, Podbean, or Spotify, so we can keep delivering expert-led content straight to you. Follow us on X at VJOncology to join in on the conversation, and visit VJOncology.com for the latest updates in the field.